Medication review of proton pump inhibitors in an FQHC, a pilot study. Hello, everyone. My name is Jessica Beebe, and I'm a third-year family medicine resident at the Wright International Family Medicine Residency Program at HealthSource of Ohio. Here's an overview of what we will discuss today, briefly 1 through 3, prior to the review of the current study. GERD is one of the most common GI disorders. Here we see the GI tract and then focus on the GE junction where pathology occurs. As a primary care doctor, we are the first line for patients when they have a problem. Here we see a generalized approach to the treatment of GERD. As I mentioned, we are an FQHC, and here are the demographics of our patient population. In this setting, patients generally try to avoid coming to the doctor. So they try lifestyle modifications at home, they pick up samples over the counter, and when all else fails, they present to the doctor and ask us for help. We recommend an 8 to 12 week trial of a PPI for GERD. However, I was getting a lot of refill requests for PPIs. So I hypothesized that patients at our FQHC were using this longer than the 8 to 12 week trial. So over the course of a year and a half, I did a retrospective chart review to see how many patients were taking a PPI and for how long. I used our residency patient panel. There was 197 patients, and I used a one sample t-test to compare the length of time our patients were taking PPIs to the recommended 2-month trial. With a p-value less than 0.05 and for an average of 25 months, I did find that our patients are on PPIs significantly longer than the 2-month trial. So why are our patients stuck on stage 3? And why does that concern us? All medications have side effects, and the longer we take a medication, the more at risk we are. So as a primary care doctor, how do we promote health and reduce harm? And what does this have to do with the FQHC, our patient population, and increased PPI use? As this was a pilot study, I cannot say for certain, but I have a few ideas. First, our patient population has significant health disparities. So when we ask them to make healthy lifestyle choices, we have to take into consideration social determinants of health if we want them to be successful. As you can see, where our clinic is located, we have a lot of transportation issues and poor resources to healthy foods. So this is very challenging for our patients. And then as a doctor, how can we help them? How are we following up? I already mentioned that they don't like coming to the doctor, and now they have transportation issues. So they're combining their abdominal complaints with their cough and cold and anxiety and diabetic follow-ups and hypertension. So we're never focused on one problem at a time. And when they need further follow-up, such as an EGD to really look at the pathology of their disease, only 30% were able to make it to the gastroenterologist. This is important because when we understand the pathology, we're able to determine what patients need to be on a PPI for an extended period of time, and then which ones can wean to an H2 blocker and possibly off the PPI. So goals moving forward. Social determinants of health play a large role for our patients. So how can we support them? Giving them education about healthy lifestyle modifications. How do we get them access to healthy foods? And how do we have recurrent discussions about the importance of behavioral change? And as doctors, how can we standardize this process so people don't slip through the cracks? Moving forward, we can incorporate lifestyle medicine and osteopathic manipulative treatment to help our patients. Thank you for listening.